I'm Bob Leibenluft. I'm a partner at Hogan Lovells in Washington, D.C. So we're discussing today a paper I recently wrote, an article I wrote for the New England Journal of Medicine that discussed the changing environment we're going to see with ACOs, and in particular the need for the antitrust and fraud and abuse enforcers to take into account those changes when they enforce those laws. Okay, an ACO is a new kind of entity that we're first going to see being established under the Accountable Care Act. It's a group of providers that agree to take on the care for a group of Medicare patients. This is a Medicare program. And Medicare is agreeing to pay some of the shared savings. If there's savings that this group of providers can account for because they're lowering utilization and are more efficient, and Medicare pays less, some of that savings will be shared with that group of providers. So there's two goals in mind with the ACO concept. One, many policymakers have pointed to the fact that the current payment system, which basically pays providers on a fee-for-service basis, encourages utilization and maybe excess utilization. So this is designed to give providers an incentive not to increase, not to overutilize services. And the second goal, so it's really a replacement in that respect for the fee-for-service system, a modest replacement. The second goal is to encourage more integration across different kinds of providers, across different kinds of physician specialties, and physicians with hospitals. So when developing the ACO concept, the policymakers who proposed it looked a lot at where were there integrated group practices, and particularly group practices that work with hospitals to provide a full level of clinical integration. And they looked at examples, for example, the Cleveland Clinic, Geisinger, Mayo. These are all institutions where typically the hospital system employs or works very closely with a group of providers, of physicians, and the physicians work very closely with each other. With the Cleveland Clinic and Geisinger and institutions like that where the physicians are employed, there's no particular concern with respect to anti-kickback laws or another set of laws called the Civil Monetary Penalty Laws, the CMPs, because these physicians are already employees of the hospital. But there are concerns where, with the ACO concept, the physicians will not be employees, they'll be physicians in independent private practice working with the hospital. And if they work with the hospital, there's two kinds of concerns. One is that there could be financial incentives which go to the providers to encourage the providers to refer patients to the hospital. And that could implicate either the Stark law or the anti-kickback law. The other concern is under the Civil Monetary Penalty Act, there are provisions which are concerned about hospitals providing financial incentives to reduce the amount of services actually that are provided by the hospital. This is actually an outgrowth of when the DRG payment system was first established, and there was concern that patients who are admitted in an inpatient stay would receive too few services. The hospital would encourage doctors to discharge their patients too soon. So between these two sets of laws, there are concerns about financial incentives, payments going to physicians to either increase utilization or to reduce utilization. And these can come up with respect to ACOs, because if ACOs are going to be functioning well, there probably will have to be financial incentives that go from the hospital or across physicians so that they work together, so they have an incentive to not utilize services that aren't needed, and to have an incentive not to use services which are unnecessary. And so each of these kinds of statutory provisions, the anti-kickback, the Stark provisions, and CMP provisions, could come into play if within an ACO there's financial incentives that affect utilization and referrals. Okay, so first of all, with ACOs as envisioned in the Accountable Care Act, they are entities that will deal initially just with Medicare, and they will be accepting Medicare payments. They're not going to be negotiating with Medicare. They're not going to be negotiating with commercial payers. So initially there won't be very many antitrust issues with an ACO that's just established to work with Medicare. Down the road, however, it may be that the ACOs also want to begin to work and contract together with the, on behalf of all the independent physicians and other providers with commercial health plans. So they may be engaged in joint negotiations with health plans, which could raise some antitrust issues. Currently, when providers negotiate together, the antitrust laws look to see whether the providers are clinically or financially integrated, so that they're more than just a group of people or providers, competitors who are trying to price fix. And if they're clinically integrated, then they're allowed to jointly negotiate unless they have too large a market share, in which case they have market power, so they could really raise their fees to health plans. The concern here with ACOs is that ACOs might form and might be clinically integrated and therefore bring some efficiencies, greater clinically integrated care, and that would be a good thing. And even under the antitrust laws, that would be a good thing, except if they become very large in terms of their market power. If they become dominant and have a large market share, the concern might be from the standpoint of the antitrust regulators that with respect to negotiating with commercial plans, they could raise their rates too high. I think this is all very much uncharted waters. There's a lot of interest on the part of the provider community in ACOs. I think it's the one part of the Accountable Care Act that's really going directly to health system reform that could lower costs, but it's really an experiment. And we'll know a lot more probably in the early part of 2011 when CMS issues its regulations on, or proposed regulations on ACOs. But we'll have to wait a lot longer than that to see whether ACOs really work and whether they have some promise.